Today our topics is USMLE Step 2 CK Hematology. It will be part 6. We will discuss about the splenectomy, remove the spleen, because in thalassemia we talk about that the child with thalassemia, we will need to give him blood. We have to transfuse him blood, in particular when both beta globin gene is deleted. So after the splenectomy, what we need to do? So this we are going to talk. We will talk about the acquired aplastic anemia, Diamond-Blackman syndrome, and transient erythroblastopenia of side, polycythemia vera, and here we talk about the step 2 CK, and I will give lecture of all my book. Sorry, probably not that much about the psychiatric, because most students already know almost the same material from step 1, but I will give lecture for all of this, including epidemiology, and my book will be available in vimeo.com, and I'm going to look for making a website for USMLEgold.com, and the student can find all the lecture on there. Probably it will be more than 300 hours, and if any student will know all of this, I can guarantee that they will do real good in the real USMLE exam, and they will prepare them properly. So students who are doing the rotation, I think when they will have time in the hospital, or they are in the cafeteria or another place, or in the car, they can listen my lecture, and I will talk everything in very slowly so they can understand properly. And same time I will tell a student to carry a book, or read the book first one time, and then look all the terminology. If they don't understand the terminology, they can look at it, what terminology I said, and just listen my lecture 2-3 times, then memorize it, and then if you can repeat it, you are ready for the exam. And I am not giving you high yield, I am giving you everything you need to do well in the USMLE exam. So it will be 300 hours at least, or close to 300 hours, if you can listen 8 hours every day, and it will be take you close to 1.5 months to do all of this. And it's one time, it will take probably 40 days, and in 3 months, 3 months to 4 months, if you listen again and again and everything, hope you will do well in the exam. And I have 15 books total I wrote each individual subject, and I'm showing you some note on here. And I not try to make it very high yield. I try to make it the student will do well in the exam. So I hope anyone will read my book and also listen my lecture. My lecture is based on my book. I'm just explaining it. Hope student will do well in the real USMLE exam. So we are going to talk about the splenectomy. After we take the spleen out, what could happen? What is the importance of the spleen in our body? When spleen will be taken out, it will be impair antibody mediated opsonization in phagocytosis against the encapsulated bacteria. How this could happen? When spleen will be taken out, we will have a defect in removal of the antigen by antibody. Antigen is the microorganism by antibody, so it will have defect in removal of antibody, removal of antigen by antibody. So antibody facilitate phagocytosis of the pathogen organism by opsonization. And how this happen? When bacteria enter into the circulation and come to the spleen, bacteria phagocyte eaten by the dendritic cell is the same kind of cell like macrophage in the white pulp of the spleen. So like say dendritic cell phagocyte the microorganism, and it causes the activation of the T helper cell. T helper cell will activate the B cell, and then it will be created the plasma cell, and plasma cell will produce the antibody. This antibody is very important to fight against the encapsulated bacteria. Which is the encapsulated bacteria? Neisseria meningitis, Streptococcus pneumonia, Haemophilus influenza. Virus is not cause the sepsis. So these three organisms, we need antibody to take them out from the system. When spleen is not there, we have a problem to produce the antibody. So without the antibody, encapsulated bacteria can cause the sepsis. If someone has sepsis, what is the sign of the sepsis? His temperature, body temperature will go high, and his immune system is fighting hard, and his blood pressure will go down. After blood pressure will go down, he will develop the tachycardia and also tachypnea. So normally antibody will bind with the encapsulated bacteria at the system, then antibody with the antigen like the bacteria will come to the spleen, and the spleen will remove this out. So when there is no spleen, we cannot do this function, and in this case we can have infection with the Neisseria meningitis, Streptococcus pneumonia, Haemophilus influenza. It can cause the sepsis. So if someone like say thalassemia infant was his spleen was taken out, so we know that this infant is very high risk to develop the sepsis from the Neisseria meningitis, Streptococcus pneumonia, Haemophilus influenza. In this case, to manage this, to prevent this to happen, because after his spleen was taken out, we will give him penicillin as a prophylaxis 2 times a day, and we will give the all kind of vaccine like say vaccine for Streptococcus pneumonia, Neisseria meningitis, Haemophilus influenza, or all the encapsulated bacteria. So it can reduce the chance that child could have infection with this bacteria. So after spleen will be taken out, what we will see in the peripheral blood smear? And we know that the spleen dysfunction can happen not only by it taken out. Autoinfection can cause it. Spleen congestion can cause it. Infiltrative disorder of the spleen. All of this can cause the spleen not to function properly. When spleen doesn't function properly, we take the blood on the peripheral smear and we will put it under the microscope. We will see the Hematology body. What is Hematology body? We take the peripheral blood and we put in a stain with the right stain, and we will see that the red blood cell have single round blue inclusion, which is the nuclear remnant of the red blood cell. So usually after red blood cell produced in the bone marrow, it come to the system, then it go to the spleen, and spleen will take out the nuclear remnant, but without spleen it will be there, and we call it Hematology body. So what is the function of the spleen? It will remove the nuclear remnant of the red blood cell. And now let's talk about the acquired aplastic anemia. What is this? Something is causing our bone marrow not to function. And what can cause it? Medication can cause it. Infection with the virus can cause it. Toxin can cause it. That can cause the bone marrow to fail. So if bone marrow, the job of the bone marrow is to produce the all kind of cell, red blood cell, white blood cell, platelet. When bone marrow fail, we cause it aplastic anemia. So he is not producing the red blood cell. He is bruising. He is producing enough platelet. So he is bruising, and he has a hemorrhage due to low platelet. And the anemia, he can has a pallor, he can has a fatigue, and if we take the peripheral blood, and we will see he could have normocytic or macrocytic anemia. His white blood cell is not produced, he can have infection that can give him fever. So he has a leukopenia, white blood cell is low. So after rule out all of this, like say patient has anemia and his red blood cell could be normal to normocytic or could be macrocytic, and the history tell that he has taken medication or he was exposed to the toxin or he was an infection recently, and he has bone marrow failure, and we are suspecting he has bone marrow failure. In this case, we must have to do the biopsy of the bone marrow to see that his bone marrow is not producing cell of the red blood cell, white blood cell, and the platelet. And after the biopsy of the bone marrow, we will see the bone marrow is hypocellular, decrease all kind of cell like red blood cell, white blood cell, and platelet, like megakaryocyte, which will produce the platelet. If person develop anemia and he would have systolic murmur with ejection due to anemia, He could have petechiae ecchymosis due to low platelet. He have leukopenia that can give him palpable a small cervical lymph node. But he doesn't, even physical exam, we will find he has no hepatosplenomegaly. So hepatosplenomegaly is sometime when blood come to the spleen and it cannot get out, and spleen is getting bigger and bigger. It can cause the destruction of the red blood cell and platelet. And in acquired aplastic anemia, we don't have this problem in the spleen. Spleen is normal. But when we see the person have anemia, person has a platelet problem and show the symptom, and he has a fever, we have to make sure that his spleen is not the cause of it. So we have to do the physical exam and try to find out that his spleen is not big. So diagnostics of the aplastic anemia would be like, he have low reticulocyte because he is not producing red blood cell. He has low platelet and his hemoglobin, hematocrit will be low. His white blood cell will be low, that is called leukopenia. But mean corpuscular volume could be normal or even could be greater than 100 FL. So after all of this, like say person has anemia, person has leukopenia, person has low platelet, and he has a history of the medication and or recent infection of the virus or exposed to the toxin, and he has all symptom, and we are thinking probably his bone marrow is not working properly, and that's why he is giving all this symptom. And in this case we have to do the bone marrow biopsy to make sure that he has a aplastic anemia. That means he has a failure of the bone marrow. And what we will see after in aplastic anemia in the bone marrow, he will have hypocellular marrow with low erythroid, myeloid and megakaryocyte. All will be low. So when we will suspect person has aplastic anemia, his all cell level is low, we must have to do the bone marrow biopsy, and we will find the marrow is infiltrated with fat, and but marrow has low cell of all three. He has a low reticulocyte and low platelet, low hemoglobin, he has leukopenia, all of this. Now let's what we'll do with this patient. And if we suspect any medication is doing it, we try to discontinue it, not to expose any, like say benzene is a toxin to the bone marrow, so we try to not to expose this anymore and take care of the infection of the virus. Probably it will be reverse the acquired aplastic anemia. Next, let's talk about the Diamond-Blackfan syndrome. This is a genetic disease, and this is considered as a congenital pure red blood cell anemia, and person could have, when you do the mean corpuscular volume, and you will find them his macrocyte, the patient has a macrocytic anemia. So in Diamond-Blackfan syndrome, patient has a defect in erythroid progenitor cell which cause the apoptosis. So so his cell is dying, erythroid progenitor cell only. Aplastic anemia, all 3 cell level, but diamond blackman syndrome, only 1 cell level is the red blood cell level. Erythroid progenitor cell, which cause the apoptosis. When erythroid progenitor cell has apoptosis, and it will result in diamond blackman syndrome, and it can cause the congenital hypoplastic anemia. Most of the infant of the diamond blackman syndrome will diagnose around the age of 3 months. And before the age of 12 months. So 3 to 12 months, usually we diagnose that the infant have diamond blackman syndrome. What causes it? We don't know. So diamond blackman syndrome, he has a erythroid progenitor cell which cause the apoptosis, so he is not producing enough red blood cell. So he will show the symptom of the anemia around the age of 6 months of his life. He will show the pallor, lethargy, fatigue, poor feeding, all of this. And patient even could be look pallor even he in his second day of his life, because he is not producing the red blood cell. This patient not only has problem in producing red blood cell, he could have other congenital abnormalities such as cleft lip, shrill chest, webbed neck, typhalangeal thumb, and definitely he will show the symptom of the anemia like pale mucous membrane and conjunctivitis. So he have also other physical deformity like cleft lip, shrill chest, webbed neck, typhalangeal thumb. And anemia can cause, like other disease, increase the rate of the heart, and he will have systolic ejection murmur as a compensation to the anemia. And because he need to pump a lot of blood to meet the demand on the body, and that's why you will see the ejection murmur. What we will see if we do the lab test, his hemoglobin hematocrit will be low, reticulocyte count will be low, mean corpuscular volume will be greater than 100. So he could have macrocytic anemia, but we know that vitamin B12 deficiency called megaloblastic anemia, and patient has hypersegmented neutrophil. But in the case of diamond blackman syndrome, we will not see hypersegmented neutrophil. And CBC we found definitely reticulocyte will be low, but white blood cell and platelet could be normal. So in aplastic anemia, we all 3 cell level, reticulocyte, white blood cell, platelet, all will be low in plastic anemia. But diamond blackman syndrome, only red blood cell will be low and white blood cell, platelet will be normal. And because he has a low red blood cell, and the physiology would try to compensate it. How we can do it? It will increase the production of the erythropoietin. When increase the production of the erythropoietin, you will see the erythropoietin level in the serum and the urine will be high. And what we will see if we do the bone marrow biopsy or aspiration, we will see there is a reduced amount of red blood cell. So because this guy have for the decreased red blood cell production. So Blackman-Diamond syndrome, we only diagnose it when the infant is 3 months to 1 year old, and only red blood cell is affected, and also same time he could show some physical deformity, and he definitely will show the symptom of anemia, and also the lab test also will tell that he has going to develop the anemia, and he is developing macrocytic anemia here. And bone marrow biopsy will see reduced amount of red blood cell. So how we can manage this guy, what we can do for this patient? First, we try to give him corticosteroid. We know the corticosteroid try to increase the red blood cell. That's why a lot of athletes try to take the steroid to increase the blood cell level that can increase their performance. So first we will give the corticosteroid, and if the corticosteroid does not increase his red blood cell, we have no other choice. We have to give him blood. So we will decide to transfuse him red blood cell, pack red blood cell. And the androgen, this is also a steroid, and we can give him androgen, and which increase the red blood cell. And we can also try to give him immunosuppressive agent like azathioprine, methotrexate, cyclophosphamide, hematopoietic growth factor. All of this we can try, but it's not give us guarantee that his red blood cell will be increased and his anemia will be solved. This is not the case. And anytime we will give back red blood cell, we will suspect that his iron load will be high. And we already mentioned in thalassemia, because when both of the beta globin chain, the gene will be deleted, we must have to give him red blood cell. So and then if you give the red blood cell, he can has hemochromatosis like symptoms. The body will start loading with the red blood, the iron, and iron is toxic to the body at a certain time. So we have to give him chelation agent like difluoxamine. Diamond Blackman syndrome has macrocytic anemia, and anytime we will see the macrocytic anemia, same time we have to look for that does he have hypersegmentation in the nucleus of the neutrophil. I'm just repeating again, because if patient is megaloblastic anemia, there is a hypersegmentation of the nucleus of the neutrophil. So we have to look at it to differentiate which is actually he has a macrocytic anemia, but which one is giving him macrocytic anemia, Blackman-Diamond syndrome or megaloblastic anemia. If you want to go to the correct diagnosis to find out what is the causing it, we have to do the look for the hypersegmentation at the neutrophil. If you have hypersegmentation at the neutrophil, it could be megaloblastic anemia. If it be not, it could be Blackman-Diamond syndrome. So next, talk about the transient erythroblastopenia of child. So suddenly child is normal, suddenly his red blood cell went down. When it happened, child is a healthy child, he has no problem, but suddenly his red blood cell went down. So it's a kind of red blood cell aphasia to the healthy child between the age of 6 to 5-year-old. They can have transient erythroblastopenia. They could have normocytic normochromic anemia. Their blood cell will be normal. Most of the case we diagnose after the age of 1. We found before the age of 1, child is totally healthy, playful, all of this. Suddenly he's showing the symptom of anemia. We call it transient erythroblastopenia, and after a certain time he will recover and he will go back to the normal again. So that's why we call the transient erythroblastopenia of child. It can happen between the age of 6 months to 5-year-old. Definitely he will show the anemic symptom, he will have pallor, weakness, but he will not show the physical deformity like Diamond Blackman syndrome has, like cleft lip, shield cyst, webbed neck, typhalangin thumb, all of this. But he could have mucous membrane will be pale and his conjunctiva could be pale. So physical exam will not find any kind of abnormality, except he will show the anemic symptom, like he could have tachycardia, he could have heart murmur and all of these, and he has like aplastic anemia like symptom, and in terms of red blood cell, he's producing less amount of red blood cell, but his platelet, his white blood cell will be normal. So only problem is he's not producing red blood cell. So if you do the CBC, we will find he has low reticulocyte, he has low hemoglobin, he has decreased reticulocyte production, mean corpuscular volume could be normal. And how we will manage this patient? He has transient erythroblastopenia. If the child hasn't show any symptom, we will just leave him alone, but we will follow him. But when it go below 4, his hemoglobin, then we will try to give him blood to prevent the show the symptom of the anemia. Next, talk about the polycythemia vera. What is this? What is polycythemia vera? Polycythemia vera is a myeloproliferative disorder. His bone marrow is producing a lot of red blood cells. Polycythemia vera is the overproduction of all 3 cell levels. Aplastic anemia, we found his all 3 cell level was producing less cell. In polycythemia vera is the opposite. He is producing all 3 cell line too much. Increase red blood cell, increase white blood cell, increase platelet. So his hematocrit value even go over 65%. Usual case is 39 to 30. For a man, 39 to 49% is the normal range, but his hematocrit even go 65%. So when his hematocrit will be go that high, he can develop viscosity in the blood vessel. So his blood volume can go high. He can develop hypertension because of it. And so anytime a person has hypertension, we must have to In physical exam you found him, he has hypertension, his blood pressure is high, and what is the next step we can do? We can do to know that his CBC level. Does he have high hemoglobin? Does he have high reticulocyte count? Does he have high count of hematocrit value? So when we will find his hematocrit value is high, then we can suspect that person could have polycythemia vera. So polycythemia vera, even child can develop in their mother womb, and they are producing too much red blood cell. Let's say the child was hypoxic in the mother womb, and in this case he can develop lot of red blood cells. When he will come out to this world, probably his red blood cell will become to the normal. But polycythemia vera red blood cell, the hematocrit value as it go high, it can cause the symptom. If it be like say close to the normal level, above, just a little above the normal level, probably child will not show any symptom. But if the hematocrit is very high, infant will start showing the symptom, and he will have plethora. What is plethora? He will have excess blood, so you will see in his system like that, and he could have, because the viscosity is high, he could have central nervous system disturbance, and he could, due to it, he could develop seizure, he could develop jitterness, lethargy, and he has a lot of red blood cell, and that can cause also cyanosis. Respiratory distress due to hyperviscosity cause the decreased blood flow to the lungs. When red blood cell go that high and viscosity will be high, and that can cause the decreased flow of the blood. When decreased flow of the blood, then the organ will get less nutrition, like the oxygen goes down, then he will develop seizure, jitterness, lethargy, all of this. This infant can also develop hypocalcemia and hypoglycemia. What we can do to these kids? If we give him enough fluid, if we don't let him to dehydrated, we always make him hydrated enough, and in this case his hematocrit value will be go down, his viscosity will be come down, and then his blood flow will be come too close to the normal, and his symptom could be managed or will be decreased, and if it be very high, we can also do the partial exchange transfusion. We can take some blood out from his body. So now let's see what can cause the increase of the red blood cell in our body. Polycythemia vera increase production of the red blood cell without the stimulation of the erythropoietin. He has high red blood cell that can cause feedback not to produce enough erythropoietin, so urine and serum erythropoietin will be low in polycythemia vera. And polycythemia vera is not caused by the overproduction of the erythropoietin, and when red blood cell count will be the high, it will give the feedback not to produce erythropoietin anymore, so serum and urine erythropoietin will be low. Another cause is increased red blood cell is the myeloproliferative disease, where red blood cells grow rapidly, even the serum erythropoietin is low. And myeloproliferative disease patient could have mutation at the JAK2 protein at the bone marrow. And so in polycythemia vera myeloproliferative disease, we have increased red blood cell, white blood cell, and platelet. And aplastic anemia also have decreased production of all of these. Polycythemia vera myeloproliferative disease have increased production of all of these. Black pen diamond syndrome only affect the red blood cell. And transient erythroblastopenia only affect the red blood cell. So what other cause increase the red blood cell production? We have to look at this. Is this patient all three blood cell is affected, red blood cell, white blood cell, platelet, or only one? Only red blood cell is increasing. In polycythemia vera, we have increased all cell level, but we found a patient have polycythemia, and we know that polycythemia vera myeloproliferative disease, his erythropoietin is low. But the other case, his erythropoietin is high. Like say for example, chronic hypoxia, person has lung disease, heart disease, and person living in low oxygen environment, like say in high altitude. Automobile exhaustion is the source of carbon monoxide poisoning, and he have high level of carboxyhemoglobin, for example. And carbon monoxide poisoning patient present with headache, nausea, dizziness can happen. And in this case, his red blood cell will be increased, but his white blood cell platelet will be normal because hypoxia caused him to increase production of the erythropoietin. If a person have AV shunt, so his blood is not going to the lung, his blood is going from the left atrium to the right atrium to the left atrium. For example, he has a hole in the heart, in the septum, or he has a hole in the ventricular system, and his blood is not going to the lung. He's developed hypoxia, and in this case hypoxia causes erythropoietin to increase, and in this case he has high level of red blood cell and his erythropoietin will be high. In sleep apnea, we have pulmonary hypertension that can cause also hypoxia. In this case his red blood cell also go high. So anytime we already know that anytime we will increase the production of the corticosteroid, that can also increase the red blood cell. And let's say patient have adult polycystic kidney disease, it can increase the production of the erythropoietin. Renal cell carcinoma, it can increase production of the erythropoietin itself. Hepatocellular carcinoma, and erythropoietin not digested. Adrenal adenoma is called the Cushing syndrome, it increases production of the corticosteroid. And anytime we produce the erythropoietin, like say adult polycystic kidney disease, renal disease, or erythropoietin will not be metabolized, and increase of erythropoietin can increase production of the red blood cell. And patient have polycythemia, and so obstructive sleep apnea, cigarette smoking, pulmonary hypertension, or sleep apnea can pulmonary hypertension, all of this can cause hypoxia. Hypoxia can increase production of the erythropoietin. Erythropoietin increase production of the red blood cell. So when we see the red blood cell, same time we have to look for erythropoietin. Erythropoietin is low, red blood cell production is high. We have to make sure we can come to the conclusion patient has polycythemia vera or myeloproliferative disorder. Patient have high red blood cells, same time erythropoietin is high, probably he has hypoxic, or he have adult polycystic kidney disease. He could have renal cell carcinoma, hepatocellular carcinoma, adrenal adenoma, and all of these increased production of the erythropoietin that can cause the red blood cell go high. So always have to remember steroid, android, all of these corticosteroid. This is all these steroid increase the production of the erythropoietin, and in this case only red blood cell will be increased, white blood cell and the platelet will be normal. But polycythemia vera and the myeloproliferative disease, all three cell level will be high. Aplastic anemia, all three cell will be low. So in chronic myeloproliferative disease, red blood cell, white blood cell, platelet increase. In hypoxia, another cause of increase of red blood cell, only increase the red blood cell, the platelet white blood cell will be normal. Like say in obstructive sleep apnea, we will only see the red blood cell will increase. Anytime I have a patient with kidney disease or liver disease or the adult polycystic kidney disease, we will expect that, or adrenal adenoma, we can expect that his erythropoietin will go high and he could have a high increase of red blood cell, but his platelet and white blood cell will be normal. So this is the end of the part 6. Next time we will talking about the clonal myeloproliferative disease and macrocytic anemia. It will be our part 7.